Our first speaker is Javier Sevilla. Dr. Sevilla is a full-time practicing pediatrician, although he must be about 1.5 times, I think, with some of his scheduled. And his practice is on the west coast of Florida, and he has a fully functioning patient-centered medical home model that he's implemented in a private practice setting with him. He also does a lot of work in relationship, is on the some boards, actually on NCQA, on their advisory board for the patient-centered medical home, as well as along with the American Academy of Pediatrics and on advisory council for the Agency for Healthcare Research and Quality. So he brings a lot of background and not only, I think, in the patient-centered medical home, but in pediatrics. So I'm going to turn it over to Dr. Sevilla.
This is a great conference, and it's really an honor to be here today. First of all, I want to congratulate all of you because this is really good. This is what we need, this framework of different community partners coming together for the medical home. And this is not happening everywhere, so first of all, I really want to congratulate you on that. I want to tell you about kind of the medical home from my perspective as a practicing pediatrician. This is my practice, Whole Child Pediatrics. It's in the west coast of Florida. And it opened in November of 2007, and the way I got interested in the medical home is kind of interesting. As Richard said, I'm involved with the American Academy of Pediatrics, with the Committee of Quality Improvement, and I had just become a member, the newest member, and there was a meeting in Washington, nobody else wanted to go, and so they sent me. And it was December 2006, and they said, it's something about the medical home, but nobody can go, so just go and see what you think. And, you know, I was there with the leaders from the American Academy of Family Practitioners, the American College of Physicians, and the American Osteopathic Association, and then was, and me there, and I was like, what is going on here? And it was one of the meetings to look at the principles, the joint principles of the medical home. So after that, I was very passionate about the medical home, and I came back to my practice. I was in a large FQHC practice, and I said, no, I really got to start from zero and implement these principles, you know, on a blank slate, if you like. So since then, you know, we've grown to. I started just with me and one nurse and one receptionist, and now we have 2 pediatricians, 2 nurses, and 2.5 clerical staff. This is the way my practice looks like right now. It's about 3,400 patients. We are affiliated with a FQHC, with a federally qualified health center, and this is my payer mix: about 55% Medicaid and CHIP, about 30% commercial, and about 15% uninsured. First of all, I want to tell you, in terms of at the national level, what we know about implementation of a patient-centered medical home. And I think you could find this article that is quoted there, I think, as a handout, and I would really encourage you to read it. This is about the National Demonstration Project. This is a project that was launched by AFP, by the American Academy of Family Practitioners, in June 2006. And it took 36 independent practices, randomized into facilitated, non-facilitated, and they gave them 2 years to transform into patient-centered medical homes. And they were studied very carefully, and this is what they found. So the first thing is that there were some things that the practices were very successful at doing. And those were components that did not really interfere with the current processes, the staff roles. And for example, open access was one of them, same-day appointments, e-prescribing. But the practices struggled with components that really needed some more fundamental changes. These were things like population management, team-based care, integration with community services. I also found that transformation was really more than just incremental changes. It wasn't a linear equation. It was much more complicated than that. That when you change something in one place, it affected somewhere else. And somebody described this as changing the 4 wheels on a car while going at 50 miles an hour. The other thing they found was that this was really a developmental process. That 2 years was actually not enough to totally transform all the processes that were being looked at. And this is the most important part. And if you don't want to remember anything else about this talk, please remember point number 5. Okay, then you can go to sleep, which is internal practice relationships. The way that the practice internally related to each other, the staff, okay, was probably the best predictor of how a practice transformed. From my experience, there's 2 things that I've learned about this process. First of all, that there is fundamental transformation that needs to happen. This is really not, as the National Demonstration Project shown, it's not a, little by little. This is really a huge transformation of the systems that we have. And the other thing is that the medical home is a journey. Okay, this is not something that you can become in a day, in a week, or in 2 months. And I don't think just by being recognized by one of the tools, you magically become a medical home. So it's kind of like success. With success is relative. It's not an end result. It's an ongoing process. It's a journey. So with a medical home, regardless where you are right now, okay, the whole issue of transforming into a medical home is to actually get in, to improve upon things that you're already doing right now. There's some people that are more advanced and some people that are starting off, but the most important thing is the act of improvement, and I think that's what really the medical home is all about. So this is the way I think about a medical home, just like a house. So you've got the roof. The roof is the most important part of a house, right? It protects the elements from the weather and keeps everybody inside safe. You've got the weight-bearing pillars and walls that support the roof, and those joints are very tight, especially in Florida. And then you've got the foundation, which is the structure that keeps the house from sinking. So this is the way that I look at the medical home. The most important part is the roof, which is the high-performance practice team. This is held by these pillars of enhanced access, population-based care, coordinated care, comprehensive planned care. And the most important part of the home is right in the middle. It's the patient and the family. The whole thing is kept together by the foundation, which is health information technology that helps us do all these things, and obviously comprehensive payment. So let's talk about that fundamental change that needs to happen for us to really go into a patient-centered medical home. So we really have to fundamentally change how we think of practicing. And these are the 5 shifts that we have to do. It's from going from caring just from the individual to caring for the whole population, from it being just physician-based to team-based, from just caring in episodes of care to continuous care, and again reforming payment so that we're not getting paid for just episodes but for comprehensive payment. And the final is probably the most important, from going from a clinician-centered approach to a patient-centered approach. So what I'm going to do is I'm going to go through each one of these, and I'm going to tell you kind of what the vision is for these, and also my journey, where I am in each one of these for my journey. So let's start with individual to population based care. So that is that little pillar. And what is the vision? Well, the vision is for the practice to keep the whole population or the whole panel as healthy as possible. And so you're not only focused on the patients that have appointments that day, but all patients assigned to the practice. The whole team, not just the physician, is going to be responsible for the health of the patients. So where am I in this journey? Well, first of all, understanding your population, understanding access. We have open access, and we know exactly how many patients call for a same-day appointment every day. So I can tell you, for example, that in the month of May, on a Monday, 12 people call every Monday morning for an appointment. And I can tell you that of every day of the different seasons. And the schedules are modified to reflect this. With chronic care, with asthma, I know exactly who my children with asthma are, and the team checks them regularly, sends them reminders, and to come into the office for services. So let's talk about going from a physician-centered to a team-based care. Who here likes jazz? Great, okay. So the first time that you go, just go back and remember the first time that you ever went to listen to a live jazz. You probably went in there and you thought, this is crazy. What is going on? You know, there's noises everywhere. People start here and over here. But then once you get to appreciate what's happening, then you realize that there's something much more organized going on. So everybody gets their solo moments with creative accompaniment. You get well-executed passing off between members, and then you get attention to rhythm of action, contemplation, and relationship. And the next time that you go to a jazz festival, or actually any type of live music group, just look at the communication, the nonverbal communication that happens between the members. And when I've gone and I've actually counted, it's actually every minute each member looks at each other and connects. And, you know, they're a high-performance team. So what is the vision? Well, the vision is that physicians focus on patients that really require a high level of expertise or have complex conditions. Less complicated patients can be handled by non-physician team members, and the physician would still be the team leader and a teacher. So where am I in the journey? Well, we have team huddles every single morning with my team. And we have regular practice meetings. And these are not just the business meetings that you usually have. We spend about 30% of the meeting just dedicated to talking about what's going on in our personal lives. And for me, as a person, as a QI geek, that was very hard to come to terms with. I like to measure things, I like to graph things, and this is just kind of high touch type of medicine, but I cannot stress enough how important this has been to transition us into a patient-centered medical home. So the nurses do outreach, they do recall, they do follow-up, and we have a care coordinator that we share with the other practices of the Federally Qualified Health Center for children with special needs and chronic conditions. This is, again, a concept that's interesting about practices. Practices are really complex adaptive systems, and the best example of these are, for example, the stock market or the rainforest. So you've got, lots of agents interacting with each other with multiple feedback loops. The interesting thing is that the quality of the relationships of the agents is actually more important than the quality of the agents. Okay? The reason this is important is that what works in one practice may not work in another, and there are different ways to achieve the same outcome. This is a very interesting article. If you have a chance to read it, please do. That looks at the best evidence-based model for how a practice works as a team. And as you can see, you've got these 7 relationship attributes in the middle, and you've got these cycles of action and reflection. So these are those 7 attributes, and these are how the practice team members interact with each other. And you can see, you can read these. You've got mindfulness, diversity of thinking, heedful, a rich and lean communication, and a mix of social and work-related interactions in the practice. You have mutual respect between the members and trust. And these relationship qualities are mutually reinforcing, creating a supportive and collaborative organizational culture. Now, you saw those webs, those cycles of action and reflection. Now, we all know in primary care, there's enough action, right? There's way enough action, but there's not enough reflection, okay? When do we have time to actually sit there in protected time and talk among our team? Very little. And this is absolutely crucial because it gives you time to share the knowledge, to fortify relationships, and to solve problems. Now, the other thing to compound to this is not just the internal practice team, because now primary care activities have exceeded the capacity that a single discipline can do. So now we have behavioral health, nutrition come in, and we probably need more team members apart from just our nurses and our clerical staff. So these are going to be part of our team also. All right, so let's talk about episodic to continuous care. Now, question, what do we sell? We're a service industry, correct? Healthcare or primary care is a service industry. So what is it that we sell? When you actually ask patients, okay, this is the answer that they give you. That what they want from you, from us, is relationships. Okay? What we sell is relationships. We actually don't sell visits. We sell relationships. Kind of like a bank. The bank sells relationships too. And this is crucial to understand this because this really puts our whole model on its head. Okay? And this illustrates that. You've got the patient coming in with preventative health care needs, biopsychological dimensions, health problems, comorbidities. You've got the family practitioner or the pediatrician on the other side with knowledge, experience. And then you've got a 15-minute visit to get everything done, right? It's impossible. There's a bottleneck. So what's the vision of going to continuous care? Well, you have to think in the way that the practice improves the health of 100 patients each day of one physician. Okay? So how can you do that? Well, maybe the physician's only going to see 10 face-to-face. Maybe the physician is going to manage the problems of 20 or 30 through other channels like telemedicine, email, group visits, e-visits. And the other team members are going to do the work for the other 60 or 70. They're going to do counseling, outreach, and just following up on acute conditions. So again, the team is crucial. This is the one that I have the biggest problem with. Okay? So we do have secure email, and the nurses do the follow-up and the outreach calls for sick and special need children, but we need to pay the rent, right? And how do we get paid? We get paid in visits, which are these artificial ways of reimbursing the work that we do. So here we go. Here's my rant. Now I'm going to get this out of my chest. So comprehensive payment, very big part of the medical home. Has the office ever felt like this? Absolutely, especially in flu season, right? So our current payment system encourages quantity over quality, volume over quality. It rewards procedures over cognitive type of visits, which is why primary care continues to be down there in the ladder of income for most doctors. And this illustrates it very well. 91214. Okay, which is a E&M code for a typical visit, complex visit. In my case, it would probably be a child with asthma coming in with an exacerbation. I'm trying to get that child from going into the hospital, right? So that child is being there. I'm probably giving him nebulized treatments, reassessing him. I'm probably going to spend about 25 to 40 minutes with him. And save, if I can get him from going to the hospital, I'm going to save the health system thousands of dollars. This is 100% Medicare using RBRBS, $100.20. This is not what I get paid, by the way. I get paid much less than that, but this is just as a benchmark. Now, who knows what code 17110 is? Cryotherapy of 1 wart. Okay? 1 wart. Now, 5 minutes at the most, right? Now the code pays $102.51, and you can put a modifier 25 and a level 3 visit, so actually you're getting much more than from saving that asthmatic child from getting into the hospital. So, should we become freezing specialists? Good question, right? Current payment system is only, these are some of the other problems, so it only reimburses for services that are done by the doctor or the nurse practitioner, nothing by the nurse, okay? And it only covers services when the patient is there in front of you. So it negates care coordination, non-visit communication. So what is the ideal payment system? Well, it should improve quality of care. It should support practice transformation, as we talked about earlier today, okay? It should incent care coordination, and it should be practical and sustainable. Yeah, right. Right. So what's the vision? Well, this is one of the theories, but maybe a risk-adjusted monthly payment for each patient with some performance-based added payments, and that the pay-for-performance payments should be shared with the whole group. And I have to say, I'm not even out of the gate on that journey. We still get basically fee-for-service. So let's talk about clinician-centered to patient-centered. So that is, again, that little green arrow. So patients or families are active participants in their care, and they receive services designed to focus on their individual needs and preferences. So where am I in the journey? Well, first of all, we respect the informed choice of parents and families as equal to mine, okay? Information sharing, all patients review their medical record after each visit for corrections. And this is what actually happened. Before I was doing this, my medical record documentation was only about 70% accurate, I'm ashamed to say. And so I started doing that, where I would just review the record with the EMR, just show and just say, let's go through this again. And when I did that, it went up to 98%. So it was actually a patient safety issue, actually a patient safety improvement. So let's talk about participation, having the patient participate in their care. We do an asthma individualized health plan that's created in collaboration with the family, okay? And allows the family to adjust the treatment and to know what to do in cases of an emergency. So this is what's happened with our asthma admissions. So we've kind of gone down, and so far in 2011, we have not admitted any of our asthma patients. Okay, let's talk about enhanced access, and that's that pillar. So let's talk about this very quickly, about other industries. So Toyota matches supply and demand within seconds. Okay, Panera Bread, if you've ever been there, okay, 6 minutes, they can match supply and demand. And McDonald's, even faster. Now in McDonald's, in the fast food industry, every 6 seconds of wait represents 1% of the market share. Okay, this is huge for industry. And enhanced access, advanced access, what's that? Well, it's not open season on physicians. It doesn't mean opening the floodgates, okay? It's just a set of principles to eliminate delays from practice. So is reducing delay important? Absolutely. It's number one in customer satisfaction, okay? Access is number one, as Nancy said before. Decreased waits improves staff satisfaction too, and it actually improves clinical outcomes, and there's plenty of evidence out there about this. The other thing is that this is expensive. Delay is actually a waste of money because you have large no-shows. You have a ton of time from the nurses and the receptionists trying to stop people from coming in. And remember this, it takes 30 seconds to say yes and 9 minutes to say no. Okay, much easier to say yes. And it gives the impression of lack of resources. Okay, most of the time there's no lack of resources, there's just that we're late at getting there for the patient. You know, this is the vision. Patients get what they need when they need it. And this is where we are at the moment. We have open access. Our average waiting time is about 14.8 minutes. And we have all patients that want to be seen the same day can be seen the same day, including well child checks. And we have the secure email also. So let's talk about coordinated care. So the vision is that the practice exchanges information seamlessly with specialists, the emergency room, that we track referrals, labs, and other tests, and that we are an active partner with specialists in the care of special needs, in my case, children. This is something that we need to work on, okay? We're doing this, we're doing the electronic tracking of all referrals, but this is one of the other things that was found from the National Demonstration Project. we can't do this alone. We need the medical neighborhood, right? Medical home, and we need the medical neighborhood, because it doesn't matter how good you do your medical home, if you're not doing the coordination of care, you're kind of stuck. Let's talk about comprehensive planned care. So the vision is that the practice provides one-stop shopping for behavioral, urgent, preventative, and chronic care, that everything is handled by the practice. And the team plans ahead with the family and develops treatments, goals, and a plan of care. So this is my journey. We have ancillary services, and we basically deal with chronic care, acute care, behavioral health, wellness prevention. We have the daily huddles, which we go and really go through each patient, seeing what they need, what they're going to need in the visit. We contact the patients beforehand and tell them, okay, make sure you bring the developmental questionnaire. And we also have care reminders about, for example, well child checks. If the child is due, we actually mail them a letter, and we call them to let them know that they need to come in. Now, the other thing that we do is we know who our special needs children are, or high-risk patients, and we have a list, and so whenever they call, it doesn't matter if they have pain in their hair, they're getting a long appointment, okay? Because it's never simple when they come in. This is something that I saw last year when I was in San Francisco. I was in Chinatown, and I saw this saying, and I thought, wow, this is really great for primary care, because I think all of us that practice primary care absolutely love doing it. We love that relationship with our patients, that kind of longitudinal relationship. And, you know, I think this is true. You know, this is something we love, and we actually get paid for it. However, there is some trouble with primary care. There's a lot of people burned out. There's satisfaction with the profession is going low, and I think this is an absolute golden opportunity for us to retake the lead, to rewrite the script, and really go forward and really create something that our patients are going to like, that we are going to like, and that the health system is going to benefit from. However, we're going to need some help, and no margin, no mission. So certainly, I think payment reform is going to help us get there. However, so far, we've gotten a long way since 2006. Everybody now has heard the word patient-centered medical home, and I think we can still go, just like we said at the beginning, just incrementally, small steps at a time until we reach that goal. This patient is the first patient I ever saw in my practice, and he's much older now. And these are one of the things that we certainly work for. So I think working in primary care is one of the most satisfying things, and you know, implementing a medical home can make it even more satisfying for our staff, for our patients, and for ourselves. Just like practice makes perfect, right? So at the beginning, when we started doing this, it was taking us 20 minutes, 25 minutes. It was very discoordinated. Nobody really knew what they were supposed to be doing. And once we were getting really good at this, now it is taking probably 7 minutes to do the huddle, because everybody knows exactly what to do. Everybody is prepared, and we have a lot of nonverbal communication in the huddle. And so sometimes I just look at my nurse, and that means, okay, you better check that lab is there. And so now it's something that we can do like this. Sometimes I do it over the phone. It's not as good over the phone. You really want that face-to-face nonverbal communication. But once you practice this, and this is something so simple, I mean, you can start that on Monday. Just get in there and just do the huddle, and then each time you just get progressively better. So the question was, if we have a 0 wait for a well child check, How can you do that with a large panel? Is that on just our practice? Is that my panel, or is that the whole practice? And we have only 2 pediatricians in my practice, so this is for both. Okay. Now, how does it work if you have a big panel? Well, open access, I mean, it's a whole series of principles. Basically, it's matching your supply and your demand, decreasing your demand and increasing your supply. And so the way we've done it is our nurses do a lot of stuff that we would do before as physicians. We have to be careful with licensing in terms of the state, but we push our nurses to do as high level of care that their license permits them to do. So they end up doing a lot of the stuff that I would do in a visit. So that cuts a lot of visits from there. And we actually max pack a lot of visits. So as somebody else in the earlier sessions, we try to get those well-child physicals done. If the patient's here for something else but they need it, we get them the service so that way they don't have to come back. The question is, if you have open access, can people make appointments for the future? Is that your question?
Let's say you come in with your 2-month-old.
Absolutely. We make appointments, the furthest that we go is 2 months. Okay, we don't go further than 2 months. Just because we find that people forget. I know I forget my dentist appointment all the time when it's 6 months. I'm like, don't even give it to me, right now. Let me call. But people can pre-book appointments ahead of time, up to 2 months, so we have appointments in our schedule. Okay. However, what we have is we know how many people are going to require same-day appointments, and we have that built into the schedule. So it allows us to have, and again, it depends. Like, for example, right now in May, I have a lot more slots that are pre-booked than open for the same day, just because there's not that many sick kids in May. So it's a lot more physicals and ADHD checks and asthma checks. I'm not doing a lot of group visits right now, but I did do them quite a bit. And the issue that we run into, and this is probably unique to pediatrics, is, group visits are great when you can have different members learn from each other. And sometimes schedules, in terms of, at least what I found, is a lot of families and parents were having difficulty saying, like, gosh, I can only make it Wednesday morning for my well-child check, and it was, and we couldn't really group different ages in the the group visit, because then you had this toddler running around and you had this so it was difficult. However, the value of it is absolutely amazing. I mean, I can tell you, I don't think I've ever felt so satisfied in terms of talking. I mean, I got through talking about every single thing that you can think of in terms of prevention, and the parents really talked a lot more than when you come for a face-to-face, 15-minute or 20-minute visit, because they feel a lot more relaxed. So I certainly saw a lot of value. I think the key is going to be, again, the physician is the constraint, and in a lot of stuff, maybe you don't need to be the person that has to be the whole time in the group visit. So I think there's different ways to do it, but certainly there's, group health has been doing group visits for a long time, and they have a lot of experience. But I have found them very, very satisfying, but tricky to schedule. If you have a very young practice, you're going to have a lot of well-child checks. Okay, if you have an older practice with not many newborns, more kind of school-age kids or adolescents, you're probably can have a bigger panel, because those people are just going to come once a year. So that's going to be one determinant. Chronic care, so the children that have chronic care, how many of those you have. My ballpark figure that I've worked with is about 1,800. Again, using your team, okay, to do a lot of the stuff that you are doing can actually help with that to expand your panel to a higher number. So I think the key is actually, maximizing your team and really using your other staff to do some of the things that physicians were doing that, for example, nurses can do very well. About payment and about payment reform, and is that going to come? Are we really going to go into, are we going to be paid for the value that we provide? And I would say I'm an optimist. So I would say there are some very powerful constituents that are pushing for this, and probably the people that have brought this really up to prime time are the employer groups. Okay, so the employer groups, the Fortune 500 companies, they are not satisfied with what they're getting, what they're paying for. They're paying for, as Paul Grundy says, we're paying for junk. We don't want to continue to pay for junk. And so they were really the ones who really pushed a lot of this primary care redesign into the medical home. I think the payers, or at least the government, CMS, is probably as close as I've ever seen it to going into this. And I would recommend you to read an article from Don Berwick from May 17th on Modern Healthcare on that magazine. And it was very clear in there that CMS is going to change payment from the fee-for-service model to an outcome-based model. Okay, and he was quoted in there. Now, I think when CMS goes there, I think the private payers are going to go there. I think really CMS is probably going to be, that's my opinion, it's probably going to happen that way around. But we've got the employers, we've got the payers, we've got the physician groups. Okay, for the first time ever, did you have pediatricians, internists, family practitioners, and osteopaths actually saying the same thing and pushing for the same thing. And then we've got the patients, the consumer advocates. They're tired of the current status quo, and they're pushing for this. They're saying, we want more patient-centered care. So I think for the first time, at least in my life, you have the 5 biggest constituents aligned on something. So I am very positive that this time we're going to go somewhere. And I think we have to keep pushing that, and we have to talk every time that that you talk with payers. We have to be on the same script, and I think that's the only way we're going to get there. So the question is, even with open access, do you still have problem patients that abuse the system? Absolutely. I have patients who know that they have availability that day and will still walk in without an appointment. Okay? They will do that. I have patients that call at 8 in the morning for a 10 o'clock appointment and no show. Now, I still don't understand that. And, and there's the usual patients who book ahead, and book multiple days. So they book an appointment here, they book an appointment there, and sure, they abuse the system. Now, what we do is and I think the whole issue about empanelment and knowing your patients is knowing, and when you have a huddle and you see that name, I say, well, 9:30, I can bet you any money they're not turning up. Let's put somebody in that slot. Okay? And I have a rule in my practice: when you no-show 3 times without calling, my receptionist, when they answer the call and you say, I want to make an appointment, they say, absolutely sure, no problem, 9:30, okay. Doesn't get put in the system. She just puts a little post-it note, and we don't put that patient in the system because they're not going to turn up anyway. Mental health is a very big issue, and certainly it's fragmented. The whole healthcare system is fragmented, as you say, and we really, one of the principles of the patient-centered medical home is whole person care, as you said. I think it starts with us as physicians. So, for example, I know a lot of my colleagues who will not treat any behavioral health or mental health condition. Okay, absolutely not. Even if it's very simple, plain vanilla ADHD. No, you're going to a psychiatrist. So I think, it goes to the comprehensiveness. I think as primary care doctors, we want to get to a point where we can take care of a lot of that. Maybe, of course, to the point of our comfort, but we want to be able to keep that in our practice and not refer out at the first kind of sign of, oh, behavioral health, no, you need to go somewhere else. So that's one, and I think the other one is coordination. I mean, I think a lot of psychiatrists say, why are you sending me this patient? This is something that can be managed in your office. So that communication with a specialist that we don't really do, and I'm guilty about for this too. When you communicate to the specialist, say, okay, what do you want me to send you, or what can I manage in the practice? What test do you want me to do ahead of time? I think that fragmentation kind of gets a little bit better. But you're absolutely right. The medical neighborhood is how we're going to address this. Now, one way that is a promise is this issue of accountable care organizations, where there's going to be a little bit more integration so that you are actually going to be paid to have that integration and less fragmentation. So that's something in the horizon that might hold promise.
I'd like to introduce our next two speakers. And Rebecca Ramsey is the Senior Manager of Clinical Programs, and David Labby is the Medical Director and Director of Clinical Support Innovation for Care Oregon. And it's a health plan that's similar to the Alliance, Medicaid, about 150,000 members. But you also have a delivery system that you're engaged in. And I just want to let you know, I've been hearing a lot about the innovative programs that the two of them have putting together in Care Oregon, both on care management and the patient-centered medical home. And just an example, Rebecca is the faculty member for the Oregon Health Leadership Council High Value Medical Home Demonstration Pilot. And David has led the Care Oregon Primary Care Renewal, which is an initiative to implement patient-centered medical home in the delivery system. And again, as I mentioned, they're very much involved in care management, some very innovative programs at the health plan, but also at the delivery level, and also involved the IHI with a number of the initiatives. And so they're going to share their experience they've had at Care Oregon with the patient-centered medical home and implementing it.
Primary Care Renewal is the name of an initiative that we've had going for about 4 years. It's to spread medical homes through our network. And we started out with 5 pilot teams in 5 organizations. So that was one clinician or a group of clinicians in their panel. And that was 2007. And we now have 80 teams in 18 practices. And the staff that did this at the health plan was basically 3 or 4 of us. So all of this was really done by them. And so part of what I want to talk about is how you create contagious change, because this is not something that we did as a health plan. This is something that we helped facilitate at the health plan, but really it was done in the practices. I'll talk about the funding that we did with that, although I think it really wasn't driven by funding. I'll talk about the payment model that is emerging out of this. I also want to talk about medical home. Every speaker that gets up has a slightly different take on what medical home is. We have in medicine something called a syndrome. When you don't really know what it is, you can list all the things about it, and like AIDS was a syndrome. So I think there's an epidemic of chronic medical home syndrome that we're all suffering from. So we're the last speakers. We get to define it. Isn't that great? So it's really fun. So we want to sort of take you through our learnings. I mean, we started I would say our journey at the medical home really started as a spiritual experience. I mean, we got totally sucked in. We want relationships. We want all this great stuff. It's going to be wonderful. And I think we're in a different space right now. And I think we have a much better idea of what, at the end of the day, the medical home has to be. And part of that is because of the environment. I mean, we are really challenged in Oregon, not as much as you perhaps in California, but they're cutting our Medicaid rates. They were saying 19%, it's only going to be 12%. Our Medicaid program pays better than yours, but still it's a real shock to the system. There is not going to be more money in health care. I don't care if it's public paid, commercial paid, everybody's had it with that. You know, we're 17% of GDP. Here's a fun fact for you. Americans are 5% of the world's population. Medical care in the U.S. is 50% of all the money that is spent in healthcare in the world. Fun fact, right? So, you know, and we are also, you know, of developed countries, we are on the low end of countries with life expectancy. So something is awry here, and for us to go back and ask for more money is going to be a real challenge, especially when that money is a trade-off between K through 12, higher education, which we know has its own challenges. I think we can say, though, and the reason I'm excited about the medical home is that, you know, if there's one value in healthcare, it really is primary care, and I think that's pretty much recognized. There's been enough literature around saying that, you know, a system that has strong primary care actually does better. They get better population outcomes, better costs, and so I think what we're trying to do, the investment in the medical home, is really an investment in a new healthcare system that will be more cost-effective and will meet triple aim outcomes, better population health, better experience of care. But, you know, I think we have to move away from the church of the medical home and the spiritual thing. We have to really get down to what is the medical home about. And we're going to show you, as part of this primary care renewal project, how over the last 4 years we've been able to cut hospitalizations by 16% in the adult Medicaid population. That's money. That means a lot to our CEO. It also means that people aren't going to the hospital who don't need to go to the hospital. And so I think that's important. We've really talked about this, you know, where have we been, where are we going, what is now demanded. I put accountability right up there. I think that you can't talk about primary care and you can't talk about medical home without talking about accountability. We created state standards for the medical home in Oregon, and accountability was one of the standards, one of the defining criteria. So, you know, for all of us, I think we have to ask ourselves, what are we accountable for? Are we just accountable for visits? Is it just somebody coming in and we see them and they go away? What are we accountable for? And I think that really is the difference between, you know, there's this whole concept of shifting from volume to value, you know, just services to value. I think we have to be clear about what our value equation is. I mean, we just heard Javier talk about outcomes-based model. Well, an outcomes-based model is going to have numbers attached to something, right? Those outcomes are numbers. And what I'm telling people is, you know, in the future, what you're going to get paid to do is you're going to get paid to move numbers, right? Numbers that have credibility. That's what your job, that's what we're going to be in business to do. So I think that as we talk about the medical home, what really gives it clarity is what is primary care about? What is it accountable for? And I think you know a medical home when you see that a medical home is producing something that is measurable. So here everything I know about the medical home is on this slide. So I would say the first question we have to ask is, why should they give us money? What are we accountable for? What are we giving them? And I think there's two pieces to that. One, we know that there are some evidence-based services, immunizations, preventive screening, chronic disease management, that we think that there's pretty good evidence that if you do it on a population basis, the population is healthier. So I think we should say we're going to be accountable for knowing who our population is and making sure they get what they need. I think we can't, everybody's going to want us to do that. That's sort of the basic medical services model, and we have to be accountable for delivering that, right? So demonstrate that our patients get all the needed services that are evidence-based. So on top of that, I think we also need to say they shouldn't have to go to the ER or the hospital unnecessarily. If we can do it in primary care, the reason we exist as primary care, effective primary care, will keep people out of the hospital who don't need to be there. right? If you have diabetes, we know that diabetes is pretty, as they say, ambulatory sensitive condition. We should be able to manage that in primary care, and people shouldn't have to go to the hospital for their diabetes or their asthma or their CHF. So, and I think we're going to be held accountable for efficiency and cost effectiveness, because there's not going to be any money. So I think we have to start by saying, what are we trying to accomplish? And this is sort of the model for improvement: aim, measure, change, right? So that's our aim. We're going to commit to that. I think that's what everybody's going to want the medical home to be, and we just have to say up front, that's what we want money to deliver. So what do we need to do that? So we have done a lot of work with the change packages, and one of the things that's always been confusing to people when you talk about team-based care or care coordination is, what are these things? What are these change packages? And are they just, is the medical home when you have a team? Because I've gone around, done site visits to lots of medical home practices who say, I'm a team, always been a team. Hey, it's me and my medical assistant, and I got a nurse over there who's on the phone. We're a team. We've always been a team. We're patient-centered. We're a medical home. We've always been a medical home. I can't tell you. I've had this conversation over and over again. So I don't know I'm not sure that that's really what we're talking about. I think what we're talking about is, what we want the things that give us those ends. So these are means. All of these change packages, whether they're team-based care, population orientation, effective leadership, they're about getting a means. And the best example of that is relationships. I would say to you, if we're just about relationships, then I think Match.com has us beat, right? But when I was listening to the Javier talk, what he actually said is, we're about relationships that improve health. Well, of course we are. So we have to prove that. So relationships are a means. The reason, that's a little bit hard, but that's the reason we need to know people, because we want to improve their health. And we have to show at the end of the day that we're doing that. So all of these things, knowing who our patients are, empanelment, we need to know that. We need to know, who are the people we're accountable for. We need to know, we need to make sure that we have open access, so they can be there, we can be there when they need us, whether that's by a visit, by telephone. We need to provide optimal medical management. If we need help, we need to ask for help. If we need the medical neighborhood to give us a consult, we need the medical neighborhood to give us a consult to make sure that we're managing optimally. We need to help people manage their chronic conditions themselves, so that holistic approach. But these are all means to the end of having a healthy population. And of course, I think we need to know the technology of how to improve health effectively. But there's another piece of this which I call the magic. All the work that we've done in all of this, it really comes down to people who really have understood that this is why they're in medicine. They wanted, improving population health, improving health is why they're there. We put money on the table. When we started this pilot, and I'll talk a little more, we gave each practice $150,000 for a year. We said, all the things you're going to do, $150,000 is going to cover it. For some, it was enough. For some, it was too little. For some, it was more than they needed. But that was about right. But really, the money didn't drive it. I think it's a total fantasy that if we pay differently, that will be enough. It's what happens. The practices that are successful are the practices that have magicians. The practices where somebody is saying, this is what I believe in, this is why I went into, I'm going to make this happen. Somebody who says, like Javier, I believe in numbers. I think the numbers are important. I'm going to be a sorcerer of numbers. I'm going to make these numbers come alive to you, right? I'm going to convince you that this tool that you have on your desktop or this registry is really about what you're doing. Because without that passion, money will never get you there. Never. Money's worth a little, but it's not worth a lot. So I have seen practices transform themselves because they had the passion and not the money. I think it's true. We absolutely need payment reform. And when we started our journey, it was about, and people said, you're going to have to pay us differently. And we committed to doing that. But the money is not enough at all. Just a little bit about us, 150,000 members. We're part of the Triple Aim. We got started on this journey in 2006 because in 2002, we had almost gone bankrupt. And we realized as a health plan that changing the healthcare system, the delivery system, was really part of our core, our survival skill. We were never going to get enough money from the state to match what the hospitals were doing with rates, what costs were doing. So we had to partner with our network to really figure out new ways of doing things that were more effective. And so we began to do a bunch of things and ultimately sort of looked around and tried to find the best primary care model, which was a medical home model. But that's what got us started. The model that we used was one we found in Alaska, the South Central Foundation. Some of you may have heard of them, Alaska Native organization. Their model was really probably the most advanced in 2006 when we were looking around. Team-based model, that basically it's a family doc, a medical assistant running rooms, a nurse care manager, a behaviorist. Behavioral health integration is key to their model, and a team assistant, all co-located in the same space. And what Javier was saying about all the people looking at each other, that co-location is magic. That really makes a difference. It's not incidental at all, because they work together as a team. And that team was told, your job is the health of your panel. Your job is not visits. So if they need a visit, give them a visit. If they don't need a visit, don't bring them in, right? And it's a capitated model, so they could afford to do that. But it was a very robust model. They involved their patients in a lot of surveys, and they had really created some incredible outcomes based on this model. So we came back from a visit. We took 30 people up to Anchorage to check these people out, and it took nanoseconds before everybody said, this is why I went into medicine. Why aren't I practicing this way? Right? We're going to go do this in our practices. It was an inspirational thing. It recruited us all to the Church of the Medical Home in a moment. South Central at that point had no curriculum, had no book. We couldn't just say, here's the operation manual. So we just sort of said, well, if we're going to do it, what is the it? And we said, well, it's probably these 5 things, and customer-driven care, team-based care, proactive panel health improvement, integrated behavioral health, big thing, and barrier-free access. And they had all the things we've talked about. They had open access. People could call into the team. Everybody on the team knew who their panel was. They'd gone through a very robust panel matching or panel assignment process. But the other thing we learned from them was that they had taught their workforce how to do improvement. And they had created a whole learning center where they taught people PDSA cycles, a model for improvement, and they'd really skilled people to do improvement. So when we started our project, we put out an RFP, asked for a bunch of organizations to try and put this in practice, ended up with 5 of our largest providers. We taught them how to do improvement. We actually got a national expert to come in and teach process improvement to all of the teams, so they knew what they were doing. They actually knew a PDSA cycle was, and so they could do it. And we brought them together in a learning collaborative, breakthrough series kind of collaborative. We agreed that none of us really knew what this was going to look like. We're all going to learn from each other. Got together every 6 weeks, traded ideas, had the process improvement coaches, trading PDSA cycles, trading new tricks. How do you huddle? How do you have a meeting? How do you do all this stuff? What works? How do you scrub a chart? And it created a learning community, and that was magic in and of itself. That really, really, really made a difference, and that really moved things quickly. Because it wasn't that we knew the answer as the health plan, it was we were learning with them how to do it as they stepped into it. It took about 8 months, but after 8 months, they got the team thing working, and they said, okay, we have one pilot team in this clinic. We're going to turn on the rest of the teams in the clinic. The other teams were rocking and rolling and wanting to go. It wasn't a straight shot. It was a lot of experimental tries. Some things worked, some things didn't. The first year was really about teams, figuring out the teams and all the stuff of teamness. But once you went to the second year, and you had 4 or 5 teams at a clinic, suddenly it was about organizational development. You can't have 4 teams, 5 teams all doing different things. So the medical director suddenly has to deal with, how are we going to deal with this? The manager has to deal with, we got some teams that really like each other, and a bunch of them, they're turning off the lights on each other. I mean, this doesn't, some people don't want to co-locate. The doc doesn't want to come out of his man cave and be part of this. So there's a whole bunch of things. So we had the engine, sort of the team, but it had to be in a chassis that worked. We got to give them reports. At first, they don't like their reports. They're always wrong. Then they start saying, where's my report? I can't possibly practice without my report. Those kinds of things that it took. But they actually took over Spread themselves. We created a steering committee. So the leadership of all the 5 organizations was sharing their practices. And it really was a learning community, and it sort of had its own momentum. In the second year, we put on the table we are willing to pay you differently. How do you want to be paid? Because what we thought was we don't want to just create another perverse incentive. We want to figure out a way in which money incentivizes change and what's important to you. How can we help you in a way that makes sense to move the ball down the court? And so the payment model has evolved, but here's a spread. This is the, as you can see, the four teams going to probably 80 teams now in 18 clinics. We co-designed this payment model, and the first iteration of the payment model was, here's a bunch of money, just keep doing your stuff, keep playing. It was just sort of, to keep you going. But we're going to put more money into moving metrics. So these are HEDIS-like metrics, hypertension under control, diabetes under control, LDLs under control. If you can move them, we just said, well, if you can move a metric 3% or 5% in a quarter, we'll give you money. Right? We had no idea if they could, but they could. Most people actually, when we agreed on the metrics, they could move them, and it began to move things down the road. And Rebecca is going to show you some of the results. Second time around, after we did that, we began to see that there were some outcomes in utilization, and so this year we're incentivizing more and more around decreasing ER and hospitalization. Next year is going to be more and more around hospitalization and ER because they have the capacity to do that. Really what we want to do is we want to align dollars with change. Really, that's really what we want to do because we want to use the dollars to pull people towards improvement. So here's the basic theory. This is an old slide. I think my CEO made this, but the theory behind all of this was, we're going to keep people out of the hospital, and the money we're going to save, we're going to put back in primary care, because primary care is where it's at. And it took us, about 2 years into this, he kept saying to me, where's my money? Where's my money? Where's my money? And in 3 years, thank God, I could say, here's your money. Not only did you get your money back, but you actually are saving money on this deal. There's more money involved, and we can, put some more money into development. So, we are convinced that this is the right road. We are convinced that this is the model of the future, partly because it deals with the triple aim in a really robust and efficient way.
So Richard mentioned that we're also known, or have been known, for a fairly innovative and effective health plan case management program. But what we have learned and what we are now believing is that much of what we've done traditionally at the health plan, things like disease management, complex case management, and dare I even say prior authorization, should really probably be the core components of an effective medical home. And so how can we enable and empower primary care practices to be able to do the work that health plans have traditionally done, because there was a gap and somebody needed to do it, and we had the business case in so many words to do it. So I'm going to actually use a different analogy than we've had lots of analogies this evening, and my analogy is the iPhone, which is timing my presentation as well. So we, one way to think about the medical home is that it's a better platform for delivering primary care. It has basic functionality that the primary care models of the past didn't have. But just like the iPhone, what really makes the medical home and gives it its power to change outcomes is more than just the fundamental foundation. It's how can you, the reason we all love these is because of all those fancy applications. You can go to a movie and it can tell you, where's the best place to go to the bathroom. I mean, that's crazy. Like 5 years ago, nobody thought a telephone would be able to beep at you and say, okay, this is a really boring scene. So go to really there is it's called Go Run Pee, believe it or not. My dad, who's a urologist, loves that. And so we believe that what really can start to transform that primary care platform are the applications, and what we can call them population health applications, that we can plug into that better primary care platform. So things like integrated behavioral health, complex case management, disease management. But the challenge is, just like it was initially with the iPhone, is how do you plug those in? How do you actually enhance this better primary care platform with competencies and capabilities that we haven't ever effectively been able to accomplish in primary care? So this is a model or framework that we've used with our clinic systems to think about what are the core competencies, the population health core competencies of an effective medical home. And they're on a continuum, and there's a reason for the continuum, and it's really based on our experience with watching the medical home practices try and build these population health strategies. On the left is what we call in our collaborative panel management, and has really become, I mean, even nationally, sort of a core part of usual medical care now, or good primary care. And I'm going to explain all of these. On your right and my left are really the areas where I think we're still really trying to figure it out. We're still trying to figure out how to plug these new applications into our better platform, and that's really how do we do chronic disease management well in primary care. And even more complicated is how do we take care of the really, really high risk and often costly patients in primary care without having to refer them out to specialty where they may or may not have appropriate access depending on the funding streams. So in our journey, panel management has really been a function that's been built into the team and is being done by medical assistants and in some cases LPNs, and in one case actually a college grad who doesn't have a medical certificate. But it's managing registries, using data, doing proactive outreach, identifying gaps in care, and really helping to plan visits. Care management for chronic conditions, I think you're all very aware of this, often requires a little bit more of a skill set, although a lot of the self-management support can actually be done as well or better by peers. And then complex case management, again, requires usually some clinical experience. And this is something that I would say at this point in our journey, we are still primarily doing this at the health plan in partnership with our primary care practices, but they're more and more, they're building the capacity to do more and more of this work. So David showed you kind of the path with the squiggly lines and hitting the swamps and striking gold every once in a while. And that's sort of our vision or our viewpoint as the health plan and working with 5 very different organizations. What I'm going to show you now is the view from one of our biggest organizations, and this is sort of their implementation path. This is a Multnomah County Health Department clinic system. They have 8 clinics and a lot of school-based health clinics. So they're the biggest organization that we've been working with. And a federally qualified health center. And I'm going to click through this. Now, I'm not going to spend a lot of time on the details behind this, but there's a couple of key points that I wanted to make. Number one, this looks linear, but it's not. And there's actually quite a bit of overlap. And I can tell you that there were forays into many of these happening simultaneously. But there is a principle of sequencing that I think we can see now, 3.5 years down the road, and they can see, which they probably couldn't have, they couldn't have spelled it out in the first year or two because they had to get there to realize, oh wow, it really did make sense that we did it this way. So, this is sort of the process or the things that empanelment was absolutely critical. And without knowing who your patients are, having appropriate data and having patients assigned to panels and having physicians and teams know who their patients were, there's no way that they could understand supply and demand and get to open access, or that they could get, all the way down, which is really where we're living right now, is in this improving chronic disease management. They need to know what portion of their panel has which condition and how acute it is. So, and in fact, there's 2 examples. One of our clinics had really tried hard to do open access, advanced access, a number of years before the medical home implementation really got started. And it was totally frustrating, and they just completely failed. And they will tell you now that they really believe it's because they hadn't attempted or they hadn't successfully empaneled their patients. There's also, Multnomah County actually had several attempts at chronic disease management, really put a lot of resources into it, and actually had sort of almost a bad taste in their mouth when this became, so we started having conversations about this needs to be a part of the medical home, because they're like, oh, but we've tried, we've beat our head against the wall, diabetes, how many diabetes collaboratives have we been through? And but you know what? They are doing it now successfully for the first time in years, and they really honestly believe, and it makes sense, that they had to go through these other steps to really effectively get the outcomes that they're getting now that I'm about to show you. So this is the fun part of the presentation. I'm going to be showing you some data, and then I feel free to ask questions at the end if it doesn't all make sense. So this is around provider continuity. So once they had, and this is just the Multnomah County view, but most of our clinics are now reaching upwards of 95% continuity. So this is really the percent of time, or the percent of time that when a patient walks in or calls and actually walks in to see their provider, that they actually see their own PCP, or the PCP on their team. So in most of the clinics, the teams are comprised of 2, not full-time, but 2 providers, and they can, they have the same panel, so they know each other's patients. So, and this is January 2011, we're up above 90% in most of these clinics now. So as a result of having good continuity and empanelment, and also, by the way, really good data that took some time to get into actionable reports, they can now do outreach. And so the panel manager function, one of the things that panel manager does is she makes sure every diabetic, for instance, on that panel has had appropriate testing and monitoring, and will call and bring patients in if they haven't. So this is just an example showing sort of the improvement that occurred once they started implementing their change package around proactive outreach. This is another example of hypertension, and you can see the numbers start to climb, and you see a pilot team that then influences a second pilot team to start making the same improvements. Open access, really, really, really hard to do, and it sounds like that's something that you're all thinking really hard about. And I don't have the details behind how the clinics actually achieved this. Some of them are doing better than others. And Multnomah County happens to be doing probably the best at any of the 5 organizations. They did spend a lot of time. They've all learned, not in addition to the model for improvement, have spent a lot of time learning lean methodology. And so a lot of what they did behind the scenes was really making sure that not only did they understand supply and demand, but that they had everybody working, as Javier said, at the very top of their license. And so they really had to build the capacity to accept the demand that's out there in the safety net in our community. So, but this is just showing that third next available is looking really good right now. It's sometimes below a day, so patients actually can get in the day that they need to get in for an urgent appointment. Right now, their goal is to have, in a pediatric clinic, to have 50% of their slots each day open at the start of the day, 40% in family practice, and 30% in internal medicine. And they do have several of the 7 clinics that are meeting that goal pretty regularly. One of the other really big efforts that was part of getting them to this, to achieving open access, was doing a whole, in lean terminology, a Kaizen event is where you actually take a team, a good representative team, out of clinic for as many as 5 days at a time. Sometimes it's 3, sometimes it's 7, but you actually work intensively as a team to work on an identified problem and come up with some solutions and then implement them. And so this is just showing that they started with an 18% abandonment rate. So when patients would call 18% of the time, they would actually hang up because it was taking so long for them to get their needs met and the call answered. And they're way down now, and that has made, as you can imagine, patient satisfaction has improved because of this. And then patient-centered care. We have actually an amazing colleague of David. So David mentioned 3 people. So the person that's not with us is Deborah Reed, and she does a lot of our evaluation. And she's also a whiz at creating and developing survey tools, really meaningful survey tools. So she developed a patient-centered medical home patient satisfaction survey after we looked far and wide for something that we thought would really capture what we wanted to measure. And it's about a 23-item survey that all of our primary care renewal clinics use with their patients every 6 months. So we actually have some longitudinal data that I don't have here right now. But there are 6 questions in that 23-item survey that really, we believe, sort of capture patient-centered care. And you can see those at the bottom, but they're doing really, the clinics, this is a compilation of all the clinics. And what you're seeing is the blue is patients that respond, yes, usually or always I get these things in my visits with my provider or my team. And the gray is sometimes or never. So, and this is actually improving each 6 months that we do it. We're seeing better results. It's marginal now because we're up there pretty high toward the benchmark. The other thing we do that I don't have data on is a provider satisfaction survey. And I would really encourage you to think about measuring that, because provider satisfaction was actually the first thing that improved when we started with those few teams. And some of that new found energy really generated that contagion and helped to really build the commitment to spread in the clinics. So here's the where the money is. This is our CEO's favorite slide. So what you're seeing here, actually it's the next slide. What you're seeing here though is ambulatory care sensitive hospitalizations are hospitalizations AHRQ has defined as hospitalizations that if the patient had access to better primary care shouldn't have happened. So, and there's 13 actual conditions and lots of diagnosis codes that go into this. But we're able to measure this because we pay the claims, so we're the payer. So we have all the claims and we can run it through this algorithm. And what you're seeing here is a pretty significant improvement over the last few years in the number of patients that are seen in our medical home clinics that go to the hospital for these ambulatory care sensitive hospitalizations. And just to sort of add it, this is an exercise that we wanted to do, is to look at, even though it's really it looks like it's only one admission less per month. The rate is per thousand. So if you actually add up all the patients and you add up the months, it's about $1 million a year that saves by the reduction in those hospitalizations. And the other point I wanted to make is that, this significant change happened before we started doing chronic disease management and complex case management. So this was really a result of all the work on the foundational elements, the platform of the medical home, not building those applications. So this is about access, it's about empanelment, it's about continuity. It's not about, I've changed the way I deliver care for diabetics. It's really I'm there when the patient needs me to be there, and I'm efficient and I'm timely. So I think that's a really important point to take away. And we can only get better with all of the chronic disease management we're doing. Here is a corollary slide. So this is looking at overall hospital admissions for our Medicaid population. And what you see is in the beginning, when we started this work, our primary care renewal clinics are the two blue lines. And they have a higher acuity population than our non-medical home sites. So originally they had higher utilization rates, hospital utilization rates. But what's pretty amazing is that those lines have actually flipped now. The non-medical home sites represented in the red have stayed the same, and the medical home sites are continuing to decline in terms of their overall admission rate. And that you saw that pattern, a lot of that is driven by ambulatory care hospitalizations. So 16 to 18% decrease amounts to about 951 fewer admissions per year. Pretty big number, pretty significant. So in terms of this next step, so what we're focusing on now is how do we empower the medical home clinics to do more population management, more care management, building those relationships that we believe are the only way. They are a means, but they're the way to get to the better outcomes that we're wanting from the medical home. And so we have learned a lot. This is actually we're in about 2.5 years now into trying to build this competency. And we didn't, you know how people like Don Berwick will always say you learn more from your mistakes than you do if you succeed. I wouldn't actually call it a mistake, but the first year that we launched into this work, it didn't go that well. We had a lot of nurses coming to a lot of learning collaborative sessions that we were facilitating, and while they were very happy with all the things they were learning, they would go back into the clinic and there just wasn't the operational structure and the leadership support for them to really step into the new work. So they had all this new skills and knowledge, but they couldn't really use it. And so what we have learned is that in addition to giving, nurses or behavioral health specialists or MAs new competencies and skills, you also, the necessary parallel work is to redefine team roles and workflows, to develop protected time, to get everything off their plate that they don't need to be doing so they have more time for care management. And if you don't do that, it's going to be really frustrating for the nurses that you're trying to empower to do new work. The other thing we learned is that incremental change is sometimes necessary. So we couldn't just jump right in and say, okay, you're the care manager and now you take care of anyone that's in trouble in your panel. We tried that. We sort of tried to just not structure it a whole lot, and what they came back and said is, can I just learn how to do this with patients with diabetes first, and then when I really get it down, then give me the CHF patients and add in the asthma patients. So they really asked us to narrow the focus so they could really use data and really learn that way. So we've done that. And then the other thing that was a really big learning for us at the health plan was, building a care management and case management program at the health plan. We have the business need is there. We're paying the bill, we're at risk, and if we can see that there's less hospitalizations if we have 5 nurses calling high-risk patients, that makes sense to us. We can do that because we're capitated by the state. But the health plan or the clinics they don't have the same model. Obviously, they're being paid on a visit basis with an additional bonus payment model that we're providing them now. So they really, as much as they were passionate about it, they were committed to it, they knew it was the best thing to do for patients, the business model was the barrier. And so we've done some work to align incentives. And so in our payment model now, we're actually incentivizing both outcomes that we know the care management is driving, but also if they report metrics like caseloads and number of outreach calls, they get a bump in their payment. It's not huge, and I'm not even convinced that they actually always feel it, but it's there and they know that we value this work, and the more they do it, the more they're going to feel that incentive. So here's sort of the approach that we took. We spent a lot of time talking with the leaders about why it failed the first time and what we needed to do to change that. And then we led with evidence-based interventions. So we focused in the last year and a half on diabetes and depression. And we're using the impact model of depression care that came out of the University of Washington. Fabulous, fabulous model. So we've got, we're supporting consulting psychiatrists who work with care managers that have been trained in depression care management. And then we also went to group health and we hired some of their an expert diabetologist and a nurse that actually has worked with diabetes for a long time. And we did learning sessions. And the other thing we did is we started with pilots. Each clinic had a pilot. And I actually went out and worked for months before they launched this to help them develop their roles, clarify their team members, develop EMR tools that would help them. Developed reports. So we really recognize you can't just turn this on. You got to have the infrastructure. And now they're doing a lot of quarterly reporting of both process and outcome measures. And most of those come right out of their EMR, so it's not overly burdensome. So here's just some early results, and I actually have even updated results, but this is looking at A1C below 8. And again, you're looking at the pilot clinic, which is in orange, compared to all of the primary care clinics. And again, this is a safety net population. And then this is looking at one of the outcome measures that we use for depression is what percentage of your patients with a diagnosis of depression have a 50% reduction in their PHQ-9 score. And so this is just showing that basically when you look at the population in the pilot team that's actually care managed, they do way better than the teams that don't have that care management model implemented. So, and I just looked at their recent data and they're up close to 65-70% now, which and according to Dr. Unitzer, who was the originator of this model, is pretty amazing in a safety net population. And then the final thing I just wanted to mention is that we're also doing a lot of work around actually doing emergency department outreach from within the primary care clinics. We used to do this at the health plan, and we never saw our ER rates improve. If you can imagine patients being called by a health plan, there's just, it's totally different to have your team member, your primary care provider or his nurse call and say, hey, I saw that you were in the emergency room last night. Can we talk about that? What's going on? Than having a health plan nurse that you may have never met before. So makes sense to do it at the primary care clinic. We actually have a way now to send every day. Our primary care renewal clinics get a list of all their patients that were in the ER yesterday. And it's in an Excel registry, and they can sort it, and they have identified, most of them have identified one person who actually makes outreach calls on a daily basis to those patients. And so here's just a little bit of data about what's happening with some of these clinics' ER rates. And this is right around the time they started implementing the outreach. So that's the first clinic. There's the second clinic. And then here's the overall, and again, an interesting story. We are not seeing an overall impact on care org and ED rates yet, because some of the clinics are doing really well and some of them haven't been able to move that metric yet. But you can see that, again, primary care renewal clinics in blue are at least staying stable. They're not increasing like the non-medical home clinics, which seem to be going up, and sometimes it's related to contracting changes. Actually, you can actually see a pattern of a 12-month bump when the contracting cycle comes up. But we're pretty excited about this, and I think there's a lot more potential. I think that's all I have. So I just, as Javier mentioned, we seem to be at a very unique time right now where there's a lot of stars aligned, and I guess, we have to decide what's going to happen. Are we going to run, dash, jump, leap across this, or are we going to get squashed? So we're going for the run, jump, leap, waddle, dive, whatever it takes to get across. We're going to stay optimistic.
One of the measures that actually at the state level, because the payment model is now being discussed at the state level, is getting advanced directives as a metric. So what percent of your patients over X age have an advanced directive, so that you've actually put an incentive in place, not that this will guarantee everything, but that conversation actually occurs. And we have a pulsed form of physician orders for life-sustaining therapy in Oregon. So it's really it's where do you can put the money somewhere, and it's like crumbs. People will follow the money. So if you want to move that behavior, you can do some things. Of course, it doesn't deal with all of the issues. I think there's a huge number of cultural issues involved in that issue, but clearly one of the things that primary care could do was to have that very important conversation.
You may not like my answer, but I very rarely use the word non-compliant. What we have found, and what our care managers are now learning because they've been trained in motivational interviewing and patient-centered interactions, is that if they can spend enough time discovering the root cause of what we call non-compliance, there's always a reason. And the trick, number one, care management and case management is not, there's always going to be patients that choose to do and care for themselves differently than we as medical providers wish they would. But given the tools and competencies and the leadership and belief that what we've been doing thus far, telling patients what they need to do, isn't working, doesn't help. So if we accept that and we start a different conversation with patients, what we do see is that some of those non-compliant patients actually do turn their lives around and start caring about the things that we wish they would have cared about years ago. So, I have story upon story, but I think we're trying to totally expunge the word not compliant out of our providers' conversations. Having care managers and other team members with those complicated patients doesn't take away from the importance of the physician and patient relationship, but what, at least currently, as you know, in this hamster wheel, those patients need more than what they can get from their physician often. And so what having a team approach allows is the patients get an enhanced experience. They get to develop relationships with more than just their provider. And so if the provider is too busy to follow up with them every 2 days because they've just gotten, they're being up titrated on their CHF medication, at least the team knows the patient and that nurse can call and check in. And, a lot of it is about communicating with the patient that we are a team and we care about you together. And so some days it might be my nurse that checks in with you, and other times when you come in, you'll only see the nurse, but I'm right there. And if she needs me, if you need me, I'll see you as well. So, we don't ever think about the team as taking away, that or diminishing the importance of that provider-patient relationship, but just as an enhancement.
The way I think about it is that's what we who are trained as physicians should be doing, is dealing with the complex patients. But there's a lot of patients that we actually don't need to deal with. And those are the patients that other people on the team can. Where there's good evidence that nurses can manage hypertension, diabetes, pharmacists can manage hypertension, diabetes, and the outcomes are in many times better than what we do as physicians. So I think our job is really the complex patient, really the diagnostics, figuring out all the dimensions of a very complex situation that isn't well defined. When things are more well defined, I think I'm perfectly happy for others to do that. Do I need to start somebody on hydrochlorothiazide every time they have a new hypertensive? I don't really think I do. So that's my philosophy. And I also think that we're going to not have enough of us to do all of that. And so our job really as trained physicians is to orchestrate a team, and that we're going to be the center of that team, and we're going to have the most complex part of that team, but we need to work with others to really have a population effect, because we're going to have to think about how we have a population effect in what we do, because there's just not enough of us. When we went up to South Central, one of the things that they had done, which was really impressive to us, is they had trained licensed clinical social workers to do sort of primary care behavioral health. So these are short interventions. This isn't therapy. This isn't let's you and I go 45 minutes and talk about things. It's really 15, 20 minute. What can you do to get you activated? And so we adopted that as part of the model. So all of these clinics have some form of behavioral health support. And I think if there's one thing that they would kill to keep, I think it's the behaviorist. It's so valuable. I'm seeing somebody who's got depression, and it's having that team member who's really good at dealing with the anxiety, depression, all of those things. Chronic pain is another one. It really gives you much more bandwidth than you have as a single individual. So that's been a huge aha for us. I think part of what we're seeing in terms of these outcomes is the fact that we're now dealing with people and not just their physical systems. We're going to have a real large number of really hard conversations. We're one of the few countries in the world where an 85-year-old will be put on dialysis. Other countries have really looked that squarely in the eye. And now I just read something in the New York Times about how some people are sort of saying, there's a medical approach to this. We don't have to put everybody who's 85 on dialysis. Maybe we ought to have different conversations. So I think, by necessity, we're going to have to be looking at what are we going to do with our resources? Because we can't afford, we're 17% of GDP, 30% of GDP. We have, by 2018, 21% of costs are going to be due to obesity. So even if the drive, the push on medical costs is just going to continue, and we can't economically sustain that. We're sort of at the tip of the developed countries in dealing with the obesity epidemic, which means that we're going to become more quickly economically non-competitive. So I just think that the physics of this, if you will, the economics of this is going to force us to face this. In Oregon, there was the infamous prioritized list. Where we in the Medicaid program, this is in the late 80s, early 90s. Governor Kitzhaber, asked the question, what's important to you as a community? And they held a number of community meetings and got people to sort of say, well, if somebody's in a car accident and they can be put back together, we'll do that. That really makes sense. But, low back pain, I'm not sure we want to spend a lot of money doing stuff around low back pain because we're not sure that it's really efficacious. So people have to, I think those are the kinds of conversations, like you said, that we're going to have to face as a culture. I just don't see, the medical home will be great, but is not the solution to the healthcare conundrum that we're in, clearly.
I think a lot of this resonated. I don't know about you, but I was going to have some coffee, but when I saw those graphs, I really perked up. So it was, I really do think, though, we really haven't had enough information about, the people that we serve. And I think we're trying to do that, I think, to understand how we can serve this population better. And I think we do have to look at these outcomes with that. Well, I want to thank again the speakers. And lastly, I want to turn it over to Alan McKay, our Executive Director for the Central California Alliance for Health, for some closing comments.
Well, let me just say, I spent the day in Sacramento talking about the meltdown of California, while the rest of you were here talking about how to make healthcare work better. So I need some love right now, because I'm telling you, it is ugly up there. It is ugly, and I would even describe it as a condition of shock and awe, because not only do we have a $26 billion state budget crisis, and I think the Alliance works in Medi-Cal, and through our Medi-Cal lens, we see some very big torpedoes coming at the Medi-Cal program. But not only do we have this crisis, we have 6 million Californians heading towards coverage in 2014. And the legislature, the state staff, the health plans, the providers are all looking at each other and saying, what are we going to do? And I would submit to you that it is appropriate to use the word, this is an existential moment. And I really like the way Rebecca finished her comments, because she said, we're at the side of the road deciding whether to cross or not. And yes, we are going to take that jump. And I would say to you that it's those of us in this room who are really vested with a very important decision. Are we going to get paralyzed? Are we going to take action? And I would say that we see kind of like two trains coming at each other. One is the train of cost, which we know is a huge challenge in healthcare, and the other train is coverage. And they're coming right at each other, and there's not a person that I talk to in Sacramento who knows how to avert that train wreck. Well, I think we do. And I would say to you, let's figure out how to do these things. Let's figure out how to reform primary care in a way that reduces preventable inpatient admissions, that reduces unnecessary ED care, that moves us in the direction of being a wellness system instead of a sickness system. Now, is that going to be easy? I don't think so. Is it a panacea? No, it's not. But I have a feeling that we have an opportunity to create a legacy, those of us in this room. It's a legacy that a generation or two down the road is going to say, you guys didn't get paralyzed, you didn't sit on your hands, you actually did something, and you embraced that process of revolution and change in healthcare. So you can see I'm kind of fired up about this, because I think the only other alternative is to let those two trains just impact each other. And frankly, I don't want to be caught standing in the middle of that. Now, there's something that really gives me hope about all this too that I want to share with you. As part of the discussions in Sacramento, I learned that all of you in this room and your colleagues in this region have the highest HEDIS rates in California in Medi-Cal. All of you and the Alliance won the state's. Y'all got lined up against 36 other delivery systems in the state. And I'll tell you, San Francisco came in #1, but all of you came in #2. And I think that's a really good place to be. And it says what we can do together as a community to meet some of these challenges of cost containment and prevention. So it is an existential moment. I think we're up to it. I think we can do it through this kind of dialogue and knowledge and idea sharing.